Hypothyroidism is the deficient production or action of thyroid hormones, namely T4 thyroxine or T3 triiodothyronine. To understand the pathophysiology, we need to know that the pituitary gland produces thyroid-stimulating hormone that acts on the thyroid gland to produce T3 and T4. Hypothyroidism can occur either when the thyroid gland can't produce enough thyroid hormone, known as primary hypothyroidism, or when the pituitary gland is defective in producing TSH, known as secondary hypothyroidism. Keeping this in view, we can divide the causes into primary and secondary hypothyroidism. The primary causes being Hashimoto's autoimmune thyroiditis, surgical resection, the use of radioactive iodine 131, and some drugs like amiodarone and lithium, and congenital malformations. The causes leading to secondary hypothyroidism are pituitary adenomas, hypothalamic tumors, the use of glucocorticoids, dopamine agonists, radiotherapy, and congenital malfunctions in the brain. So how does hypothyroidism present clinically? Well, it can manifest in various ways. Patients often experience fatigue, weight gain, cold intolerance, constipation. Females experience menstrual irregularities, depression, and cognitive impairment. If left untreated or undertreated, it can complicate into cardiovascular issues, myxedema coma, infertility, birth defects, and mental health disorders. When diagnosing such a patient, we get the thyroid function tests, in which we'll obviously see low triiodothyronine and thyroxine levels, and the TSH levels will determine whether it's primary or secondary. In primary hypothyroidism, the TSH will be high, while in secondary, it may be low or even within the normal range. When managing such a patient, we need to replace the hormones using levothyroxine, a synthetic form of T4. If the patient does not have any comorbids, we can start off with 1.5 to 1.8 microgram per kg per day. But if the patient does have any comorbid, we need to give a higher dose of 12.5 to 25 micrograms per day. Now, according to Davidson, we usually give 50 micrograms per day for the first 3 weeks, then moving on to 100 micrograms per day for the next 3 weeks, and then keeping the patient on 100 to 150 micrograms per day as a maintenance dose. And the most important bit is educating the patient about their condition so that they know what to expect.
Thanks for watching, guys. You can go check out more videos on the channel. Do leave a like and subscribe for more content like this. If you have any questions or suggestions, you can leave a comment down below. I'll see you next time.